And if we have any questions out there, JP.
Just want to get everybody into the mix. So 2 questions, one for Grant and one for Peter. So Grant, is there ever a case where the augment is challenged by the stiffness of the subscapularis even after you do releases? And can you identify that before you try to put it in? And for Peter, as I look at these inset glenoids, we know that the kinematic contact pattern and motion for the shoulder is not centered. And so much of the time when you're moving the arm like this, the contact point of the humeral head and the glenoid is outside of the implant you're placing, especially in, like a significant retroverted glenoid. What do you think about that? It's a little confusing for me to understand how it makes a difference when it's not directly contacting the humeral component throughout the arc of motion.
Yeah, two great questions. So I'll take the first one, obviously. The subscap, I haven't had an issue with that. Again, kind of using that Jerry Williams style capsulectomy. What I have had an issue with sometimes is the posterior cuff. So if you think about if you have like a type C glenoid or something where their cuff is not under a normal link tension relationship, that's one where I'd be very cautious about using an augmented anatomic because they're going to have a lack of internal rotation. That cuff is going to be very tight posteriorly, even if you release things. And again, that's one where I would say I wouldn't necessarily do a concept of restoring the version in those patients. I might do something more like what Peter showed in a type C. Peter?
Yeah, I think that's a absolutely phenomenal point, that part of the problem is you don't get as good a coverage. And with an onlay, you can really cover the whole glenoid. And then if you have that translation that we know is occurring, you know that your contact point is still going to be within the face of the glenoid. Whereas with an inset, especially if you don't get very good coverage and it's really centered, you may find that the glenoid is slipping onto the native bone. And I would argue that's got to cause some residual discomfort for the patient.
All right, this question is for Hot. So, great talk on pyrocarbon and exciting for what it means for the future. So the question would be, how do you see this evolving? Do you see this evolving towards more standard arthritis cases? Have you done it in cases like that? And if so, what have you seen?
Yeah, I do actually, because I've been in practice for 21 years, interested in shoulder for longer, and we're still struggling with polyethylene. So there's something inherently hard about polyethylene in the shoulder, harder than in the hip or the knee. So, in short answer to your question, I think people are physiologically young, have a pretty long lifespan, and you can talk and you don't know for sure, but you can guess. Healthy, have a little bit of resilience and grit, and I'd say 80 to 90% of my patients do. They just want to get back to life. Those patients all become better candidates in their 60s. I haven't done any in their 70s yet, but 60s I think for sure. People want to be active. In Colorado, a person who's 65 looks like they're 55. Half the time. So if a glenoid's going to last 10 years, or maybe even 15 years, they still have to live with kind of a crappy shoulder when that plastic loosens. And older people just live with a crappy shoulder. Yeah. It's loose, they don't like it, but they're too old to do anything about it. So with the pyrocarbons at 7 years now, I'm seeing these patients, they are staying the same or getting better. They don't think about their shoulders, most of them. And they're not getting a ton of glenoid wear. So I think it's the closest thing we have to one that could possibly last the rest of a person's life who is an active person. I don't know for sure, obviously, but I think conceptually it is possible.
You got it. Bill.
Armand, great talk. Can you, we're really good in orthopedics at the latest widgets and the shiny new toys. And then we sometimes have to take a step back. So talk a little bit, in your systematic review that you did with OK's group, you had about a 23% glenoid erosion rate at 2-year minimum follow-up, and a 7.7% revision rate. So it's not perfect, nothing's perfect, but how do we look at that at 2 years, which is pretty short term, and already see 23% glenoid erosion, and put that into perspective for what's going to happen after that?
That's a great question, Bill, thank you. So for sure there's medialization of the glenoid in the beginning. In my case, it's a lot of times iatrogenic, because if you correct a B2, you're going to get medialization just because of the correction itself and making a new concavity. What we're finding now, and the results are preliminary as I showed in that slide, is that initial erosion or medialization, whatever you want to call it, is significant in the beginning. It's about 3 to 4 millimeters on average, but it's more in some people. But then it tends to slow down over time in our group. There's some other articles from Europe, not quite as systematic because there's not good follow-up, that show that there's not much progression also. But I'm not into those articles as much as I am looking at our own patients, because we know what we have. As far as the revision rate, it's high because there's a lot of resurfacing pyrocarbons in those, and that's a different implant than this one. And they were fracturing all over the place. There are actually news stories you can find on YouTube about patients saying, yeah, I went to Australia to fix my shoulder and now it's broken and I'm horribly dissatisfied. So remember, it's a ceramic, it's brittle. That's why I think the resurfacing concept, even though the Aussies swear by it, is maybe flawed a little bit. It's also not convertible. So that's why this stem and this implant is different. The results aren't quite as long-term on that one because it's a newer implant on the market. So, but I agree with your concern about new widgets and not getting too crazy about them.
Awesome. Well, thanks to this panel. Good talks.